fasting is really practiced in different religions. In the Orthodox, soon you'll find that the Easter is coming, so the Orthodox will fast for 40 days. In Islam, you know that currently we are in the holy months of Ramadan, and the fasting is somewhere we are in the mid of that fasting. Hindu, every religion had their own fasting, and also nowadays, as part of the healthy lifestyle, people have different types of fasting practices, including intermittent fasting uh, or also some prolonged fasting. But in this discussion, my focus and most of the available scientific literatures focus on what we call the time restricted feeding, which now more or less resembles with the kind of religious fasting we're talking about. So my focuses with that type of fasting, where food intake is limited to certain hours across the day. And this type of fasting really aligns with what we call the circadian rhythm. Our body has its own clock. There's a time where we'll sleep, there's a time where we'll wake up, and with the time where the blood pressure will be high, the time where the glucose level will peak, the cholesterol synthesis will be peak. They differ over the 24-hour period. So we'll pick this concept of circadian rhythm later on advising patients on how they can adjust their medication during fasting. But as a principle, fasting is known to show that it improves insulin sensitivity, especially in diabetic population, muscle metabolism in terms of reducing inflammation, in maintaining the body weight. It has really proved a lot of health benefits, including prevention of cancer, because one thing that fasting does is it reduces the intake of carbohydrate, glucose, and those things really precipitate tumor growth. That is one thing, okay? Fasting really reduces hormone secretions, and hormone-induced cancers can easily be also related by fasting. And this also aligns with the definition of health we have. The old definition of health is to say health is not a mere absence of disease, rather health is physical, social, mental. That was the first definition that was given to health, but other two scholars added health is also, there is what we call spiritual and emotional type of health. So when people fast, they build on their spiritual health and is really believed to contribute a lot on mental health. So you can see this picture showing the different roles of fasting in terms of metabolism of macronutrients. In terms of lipids, you can see fasting has a role in lipolysis, okay? In hormonal actions, it has a role in increasing insulin sensitivity, for example, in reducing insulin resistance. In protein metabolism, carbohydrate, fasting has a whole set of advantages. Now, when we read about fasting as a pharmacy professionals, we believe on evidence-based pharmaceutical care service. So some of the issues we are having is most of the researches in fasting were done on healthy adults, number one. So not really, you don't find most studies on either diabetic or epileptic patients. So we'll try to pull concepts together to come up with an advice or tips for individuals who wish to fast, and then they are on maybe anti-epileptic medication, or they are on asthma meds or antiretrovirals. Maybe later on we'll try to mention. The other thing is there's really limited data on fasting, especially in underweight individuals, in elderly, and on pediatrics. In the earlier slides, I've mentioned a lot about the advantages of or the health benefits of fasting. At the same time, with fasting, in the next slides, repeatedly you listen to the word dehydration is associated with fasting. That is why we advise people on fasting to take plenty of water, minimum of 8 glasses. For example, our colleagues in the months of Ramadan, if they are fasting, they are advised to take plenty of water between the time, the morning or to suhoor time, 8 glasses or plenty of water distributed on that specific house, okay? Caffeine withdrawal could bring about of headache, for example. That's why dehydration could be associated with fatigue, dizziness, and also headache. So that is why some of the side effects you could see. And more than 3 times of hospital admissions during month of Ramadan could be due to patients on asthmatic medicines because of you see the spiritual health component, and you see this also a community. So you are in the middle of a community and need not to be stigmatized. So most patients will stop their medicines during especially the months of fasting in any of the religions, okay? But based on documented research, which I'm talking, you could find high level of reporting on patients stopping their anti-asthmatic inhalers and finding themselves in emergency ward during months of Ramadan. So it's very important to advise patients on how to cope with their asthma medicines in the months of Ramadan or during fasting. Now, let's go to the real matter. Let's see the 4 big pillars of kinetics to understand what has really happened. Now, colleagues, I need your participation where I'm displaying a case study. And let's read the case study and now look at the chart for your response. The case study reads, this is a 60-year-old male patient with atrial fibrillation. Look. And you could have these patients on digoxin for atrial fibrillation or flutter. And you see in the months of Ramadan, it is very difficult to advise them to not to take their medicines because it's very important. Let's really read the case study. This guy is fasting and takes his medication immediately after breaking his fast with a fiber-rich meal. What is the most likely impact of fasting and meal timing on digoxin absorption? Let me see your answers. Use the chat box to respond to this question. What is the best answer? Let's wait for answers to come. Do you think fiber foods increase absorption of digoxin, or will they have no effect, or could they delay elimination? Okay, I can see people responding with A and B. Good. As we wait, the answers are coming. Let's really proceed to the discussion and we'll answer this question. My first talk will be what some of the absorption changes during fasting. Okay. Basically, as you know, drug absorption is really influenced by the gastrointestinal motility, meaning if there is less movement, then absorption will be less. Okay. Drugs that can affect the pH, the acidity of the stomach, okay, including biverates, antacids could affect also absorption. So when it comes to fasting and of the time where this fasting happens and the time of eating, for example, in Ramadan, you can see fasting delay gastric emptying and reduce bile secretion, and this could affect bioavailability of a number of drugs. So one of the key considerations here is, let's read this bulletin. Fasting during Ramadan limits oral drug administration because imagine you have just 3 to 6 hour window at night. So imagine if you have a patient on chronic illness and if the patient is prescribed to take medicine 3 times per day, for example, in some patients with severe seizure attacks of epilepsy, and they are supposed to take their medicine twice or 3 times per day just to control the seizure. So, you have very few periods of time. So it's very difficult to optimize the therapy within that time. So here is where you advise that patient to have a talk with his doctor, with his imam, or with his religious leader or pastor in a way that he understands or she understands that in such kind of cases where they are having multiple doses to be taken in a day, they cannot be advised to fast. And the good thing in Islam, it really considers individual's health, and that is, I think, well noted. So the other important consideration in the circadian rhythm and also drug absorption, as I told you earlier, for example, the blood pressure is usually high in the morning and less at night. So, you usually advise patients to take AC inhibitors or ARBs, preferably at night. Okay? Usually because it can give them a good BP value in the morning, or it reduces cardiovascular complications or cardiovascular events in the morning. If you see digoxin's absorption, for example, is very higher in the morning, with very shorter time to peak. Look anti-inflammatory drugs. The cytokines production is very peak at night. So if you need to prevent pain at night, the best time to administer NSAIDs is at night. So when you think of this circadian rhythm, it's very important to consider fasting plus circadian rhythm plus the time of drug administration. The other important point to note is the fast-breaking meals. What are the meals to be taken when people are fasting? Okay. Basically, even though my topic is not nutrition, it's heavily advised to take nutritious, rich foods during fast-breaking meals, high-protein-rich foods. High-protein-rich foods are very good to help muscle mass, but later on, again, we'll see in metabolism, consumption of high-protein meals a lot could also impact metabolism. They could increase expression of drug metabolizing enzymes like cytochrome P450. The high foods are very essential for brain so that the brain will get adequate energy and will not end up in energy, or to prevent an energy crash. Come to carbohydrates. Complex carbohydrates are very important. Those carbohydrates which will have especially, which will take time to disintegrate or to break down, they are better to be taken, for example, at breakfast or at suhoor time, so that the individual, the person will have consistent or steady state glucose concentration during that time, and so the energy fluctuation will be less. So considering all these fast-breaking meals, it took us to a real assignment as a pharmacist to consider what is the possible drug-food interactions. Take, for example, in the earlier case, taking off high fiber-rich foods. You see they could decrease gastric emptying time, and they could decrease absorption. So we need to advise patients at least to have a time gap. Take, for example, thyroid replacement therapy that are very fundamental. You cannot a slight switch on the plasma concentration could cause a lot of hormonal imbalance. So if you give it with high fiber rich foods, then again, absorption will be reduced. So the home take message is foods rich in fiber, if they are taken as part of a fast break meal, they reduce drug absorption. That is one home take message. The other part, what are lipophilic or high-fat meals? It's very interesting. High-fat meals are always controversial. In one side, they are good to increase or to help absorption of some antifungals and some drugs for acne treatment. This is okay. They maintain plasma half-life. However, if you give high-fat meals with some drugs, take, for example, antiretroviral efavirenz, high-fat meals increase the absorption of efavirenz. What is the end result? The CNS toxicity, which is the typical side effect of efavirenz, will increase. So we don't advise patients on antiretroviral drugs to take high-fat meals at the same time with their medicines. You see now at the same time is also very academic, because imagine if it is the iftar time, for example, and after a small carbohydrate iftar, then when he's eating the real dinner, if there is high fat meal, you see, that is the only time this person will have time to take his efavirenz, you see. So for such individuals, it's very important to tell them eating high fat meals at dinner will increase the CNS toxicity of these antiretroviral drugs because it enhances bioavailability. You also think of this propranolol, okay? Fatty meals in one side for glycofulvin, for isotretinoin, and also efavirenz, we said it increases absorption. For glycofulvin, Good. 45 grains, very bad toxicity. However, when it comes to propranolol, 40 mils will increase absorption, which will now affect the BP control. So now is where the time comes to advise clients to have a timing, to have a talk with their healthcare providers and also religious leaders on how to cope with their medicines. Take, for example, grapefruit juice, and juice is very common. Usually people use for breaking fast. The problem is some of this juice, typically grapefruit juice, is well studied. It inhibits the drug metabolizing enzyme. As you already recall, drugs enter the body, and it's very important their dosing is fixed. Or when we talk of a dose of a drug, there is at the back of these signs, there is a consideration for their clearance. A certain amount is believed to be bound with albumin in the blood. A certain amount is believed to be excreted. So what happens if some food items like the grapefruit juice, if it inhibits the cytochrome P450 enzyme, the effect is toxicity. The drug will accumulate. So drugs like atorvastatin, this statin, so will really accumulate. Just to mention one point, simvastatin is a very short-acting drug. So patients on cholesterol controlling drug, and earlier I talked with the cholesterol synthesis. Cholesterol synthesis is very high at night. The short-acting drugs like simvastatin should be taken at bedtime, but this is not one thing you can contribute. Another option is shifting to a long-acting compounds. Instead of giving twice per day in case of simvastatin, but it is possible to shift to a long-acting drug like atorvastatin. But advising the patient not to take grapefruit juice with these statins, with calcium channel blockers, antihistamines. You can imagine what could happen if there is toxicity of calcium channel blockers, which are vasodilators, and the hypotensive crisis will be a lot. Antihistamine, the sedation could be a lot. So to avoid that is very important to advise. And remember, you cannot solve this problem by time gap. Earlier, we said the fiber and digoxin, you can do time gap, 1 hour or 2 hours. But interaction at metabolism level, you cannot solve it by what we call timing. Also, it's very important to think of other supplements, okay, like with coffee, okay, because tannins in the tea, in coffee, they could really reduce iron absorption. And that is one important point to note and appreciate here. So when we come to our earlier case study, I believe those of you who said the choice B, you are correct, because we have established that fiber binds to digoxin and it reduces its bioavailability. Good. So what are the key recommendations with regard to absorption? We said adjusting medication is very important. For drugs that are given at least twice per day, it is very important. So the first thing before you say, take the drug at iftar and suhoor or during fasting hours, before the fasting season starts, it is very important to prepare patients to change their food, their diet to twice per day, so that the body can be used to the fasting season. The same is true to adjust the body for post-fasting season. After the fasting season is over, when the body turns to the normal routine, again, is very important to adjust, very important to ensure consistency of rehydration, consistency of limiting sugar intake. Those are very important points. This bulletin, I would love to really make a very strong point. Consider, whenever it is possible, it's good to consider long-acting or extended release formulations. That can really help you with those fluctuations. Good. Let's come to distribution in kinetics. Let me give you this case study. Let us all read and try to respond. This is now a patient 70 years to CKD stage 3. He is given gentamicin, and it's a hydrophilic compound drug. How might fasting impact gentamicin? Okay. Yes, let's see the answers. Colleagues, if you are there, please give your answer in the chat. I'm following. What is the option? How do you think fasting could affect a drug distribution? Excellent. I can see Hashim had answered saying yes. Rose is answering yes. Shah, very good. Very interesting. People are answering saying it could decrease volume of distribution. Let's quickly see. I know my time is running. So basically, what is drug distribution? After absorption, a drug enters into the blood and will be distributed all over the body. There are two important kinetic criteria. That is volume of distribution. The drug will distribute to different parts of the body. And the drug could also bind to tissues and bones. That is what we call fat deposition. During fasting, as a result of dehydration, the volume of distribution will significantly be affected. Not only that, it's shown that there is a significant weight loss and also a protein loss you could see during fasting. That means if there is low level of protein, that means that the albumin level will also decrease, meaning drugs which will have high protein binding will not get the adequate albumin to bind in the blood, you see? That is why eating nutritious foods during fasting is very important to maintain the normal albumin level. That is why drinking plenty of water during the fast break hours is very important to ensure rehydration and to ensure the volume of distribution is consistent. With that, you see, as I mentioned, fasting could affect the protein binding. It could affect drugs like gentamicin because the volume of distribution has decreased. So the drugs may not distribute, so there could be toxicity. So dose needs to be adjusted. So those of you who answered B, you are correct. Fasting could decrease volume of distribution and could cause an increase in drug accumulation. So what is the home take message? Ramadan fasting could lead to what? Modest weight and metabolic change. Even though it has minimal clinical impact on drug distribution, is very important. At least some of the things we can do is to advise patients to have a nutritious diet. It does not mean fatty foods. They can get the fatty foods from nuts, from seeds, okay? Adequate protein-rich foods, okay? And also plenty of water for purpose of hydration. The next and the last part of this discussion will take us to the drug elimination or metabolism. Very interesting point in the next few slides. Let's attempt this case study. Let us do it together. Now, this guy is taking omeprazole and midazolam. The question is, how will fasting affect the drug metabolizing enzymes? Hope you know that metabolism happens in the liver. And metabolism is done either phase 1 or phase 2 metabolism. And in phase 1, basically, it is the cytochrome P450 enzymes that are involved. Yes, phase 2 is glucuronidation. I can see Felix, Cyprian, Dorothy. People are answering B. Let's see this one. Yes, metabolism could be affected by a number of factors, function of the kidney, patient characteristics. Also, nutrition and fasting could have a role in metabolism in either phase 1 or phase 2. Scientists have really studied the metabolism. This was one of the most studied things in kinetics. They have studied the metabolism of warfarin and all the other drugs you see, including the skeletal muscle relaxant, the doxazole. And what they found out is, number one, fasting would increase some of the metabolizing enzymes, of which CYP2D6 Hope when you hear this enzyme, you remember of codeine. This is the same enzyme that metabolizes into morphine. It also decreases the systemic clearance of some drugs. Maybe now this is where you be cautious of toxicity. You can also see the effect on midazolam metabolism. So after a thorough study, the conclusion is the following table. There is significant increase in the cytochrome P3A4 isoenzyme, and remember 90% of drugs out there in the market are metabolized by this isoenzyme. So capture this slide. The home take is fasting could increase the following enzymes: 1A2, 2D6, and 3A4. As a teacher, I'll give everyone a homework now. What are those drugs metabolized by these enzymes? You know, the home take message is, if fasting is going to induce these enzymes, that means any drug that is metabolized by these enzymes will have lower efficacy. The effectiveness could decrease. That is why there is nothing you can do. I'm not saying just increase the dose or double, but is where monitoring will be very, very crucial. Fasting, as a result of all this, it could increase the clearance of like metoprolol, which is one of an important drug in CHF with hypertension, midazolam, an important anti-anxiety drug. It could decrease the clearance of warfarin. So it's very important to monitor INR of patients on warfarin therapy so that to prevent either extreme coagulation or bleeding. In this case, that is a risk we are so worried of. Therapeutic medicine, this is a whole thing, the whole thing. And let me say this one, when it comes to epilepsy, especially newer patients which are put on anti-epileptic drugs are not advised to fast, because a slight fluctuation, plasma fluctuation of the anti-epileptic drugs, especially in the first 1 year of epilepsy, could trigger seizure occurrence. People with more than 2 to 3 seizure attacks, or who have repeated seizure attacks and who are more than 1 or 2 drugs with unstable seizure control, also they are not advised to fast. That is very, very important when you see phenytoin. That is what I try to explain with narrow therapeutic index products, because narrow therapeutic index drugs, a slight dose increment could cause toxicity or the other way. A very interesting point for those interested in oncology is also, you know, some anti-cancer drugs are prodrugs. For example, is irinotecan, which is one of an excellent drug in solid tumors. It needs to be metabolized to an active product, that is SN38. And that metabolism happens by CYP3A4. You see? So what happens is, as a result of fasting-induced CYP3A4 may lead to reduced SN formation and then to treatment failure. So in general, fasting could affect drug metabolizing enzymes. For this question, you have answered B, that is correct. Fasting increases CYP3A4 activity. If the enzyme level increases, the activity of midazolam will decrease because the plasma concentration will decline. Finally, with regard to renal excretion, can we quickly look at this question? I know my time is, I hope I have a few minutes. See vancomycin, okay? And this patient is experiencing dehydration with prolonged fasting. So what will be the effect of fasting? Can I see the charts? I can see someone was asking about effect of intermittent fasting. Yes, Metropolis, excellent. People are answering B. Shanice, Winfred, I think we are good. Because the answer is, I think, very clear. Because fasting could cause dehydration, okay? And that dehydration would decrease renal excretion of a lot of drugs. lot of drugs. That is very important. So fasting could reduce renal excretion due to dehydration. If renal excretion decreases, then that means drugs plasma concentration increase, which will precipitate people to toxicity. And your answer is very correct. So what are the key recommendations as a result of excretion? We said fasting affects drug metabolism. We have seen how it affects the cytochrome P450 enzyme. And also, it could affect renal excretion. It's most unaffected in healthy individuals, you see, but it could impact people with CKD and transplant. Drugs with narrow therapeutic window need close monitoring. That is why we said we advise patients have a talk, have a plan with your doctor or religious leader. Could be imam, could be a pope, or could be a pastor. Metabolic and excretion changes may require dosage adjustment. That is why we always say monitoring is very fundamental. As I wrap up my presentation, I know I've talked a lot. It's very important to have a patient-centered care. In patient-centered care, it's just to have time for patients to reflect on their plan on how to walk the journey to the success of their treatment, the success of their fasting. If we implement a patient-centered approach, then it's very possible to help them to attain their spiritual goal of fasting without compromising their health. With those many words, colleagues, thank you very much. I welcome any question later on. Back to Dr. Cohen.
Thank you, Prof. Ermias. That was a very informative presentation, like many have attested in the comments. For those in session, please, if you have any question and answer, please write your question in the Q&A tab, and Prof. Ermias and the other panelists will answer the questions. We'll have a Q&A session at the end. I've seen so many requests about the slides, so Prof probably will tell us how, together with Dr. Hezron, if the slides can be shared for those who have attended to go through them, because very many have requested for the slides. So right about now, we'll go to our second speaker, Dr. Bushra, who's going to talk about pharmaceutical care during fasting. Dr. Bushra, if you can hear me, please take it away.
Good evening, everyone. Thank you, Cohen, and thank you, Prof. Ermias. That was a very informative presentation. So mine is about pharmaceutical care during fasting. And I'm just going to share my slides in a few, and someone can confirm if you can see them.
Yes, we can now see your slides.
Okay, great. So mine is going to be brief. I'll do my best to keep it within the time limit. And I'm mainly going to talk about how a pharmacist can contribute to patients who are fasting, particularly for chronic illnesses. So that's a brief of what I will go through. And like Prof. Ermi said, fasting has been observed for millennia, and hundreds of millions of people around the world fast for various reasons, or maybe religious reasons or medical reasons. And basically, when it comes to the religious aspect of it, because everyone wants to be a part of that and gain the benefits of it spiritually as well as physically, we have patients with chronic illnesses as well who want to participate in fasting. So when it comes to that, we know that patients with chronic illness have medical risks, and because of that, there's medical interventions that are involved. And pharmacists are actually in a really good position to give advice and support such patients on how they can fast without affecting their health, how they can keep up with their medications, ensuring adherence and safety. And fasting, like we all know, basically is abstaining from food drink, or both of those for a particular period of time. And in other situations, like for example, in the month of Ramadan, fasting also involves abstinence from oral medications, from IV nutrients, from smoking, sexual activity, and even from sin. So it's not just the physical aspect of fasting, it's spiritual as well. And we have different kinds, like Prof already informed us about intermittent fasting. We have absolute fasting as well, where individuals fast for about 12 to 20 hours without any food or drink at all, like in Ramadan. We have partial fasting as well. Partial fasting involves a situation where a patient is going to maybe eat and drink, but like they will stay away from particular foods like grains, legumes. And fasting for religious reasons, we have examples like Ramadan. There's Lent for the Christians. We have Yom Kippur for Judaism and Ekadashi in Hinduism. And all of these have different principles on how an individual is going to fast. Like, for instance, during Lent on Fridays, all Catholics aged 14 and above abstain from meat. Anyone can correct me if I'm wrong about any of these. My apologies for that. And for Judaism, when they fast for Yom Kippur, they fast for a complete 25 hours without food and water. So there's all religions that actually practice fasting in different ways. And according to religious laws and according to health laws, we know that individuals who can fast are sane individuals, individuals who are healthy. So if someone is unwell or they're sick or something, and it's a condition where it's going to affect their health medically and all, so those kinds of individuals are exempted from fasting. And Islamically, anyone who's attained puberty is sane and healthy is recommended to fast. It's actually compulsory because it's one of the pillars of Islam. So when an individual is fasting, there's a lot of lifestyle and physiological changes that happen. We have changes in timings of the meals. Like in Ramadan, there's 2 meals where we have the pre-dawn meal called suhoor, and then we have iftar, which is the evening meal at dusk. And then the amount of food changes as well. You tend to eat less when you're fasting for a long period of time. Like in Kenya, Muslims fast for 13 hours. So at the end of the day, you're not going to be able to eat as much as you do on a daily basis. We have changes in sleep pattern because of the pre-dawn meal. So that's going to affect your circadian rhythm, and in turn, that also affects your metabolism. There's hormonal changes, and the Prof. Armias already covered a bit of that. So when you're fasting, like in Ramadan, you're staying away from food and water. So at that point, your body goes into gluconeogenesis and glycogenolysis. Because you're not taking in any food, there's no there's no food that's coming in to be broken down into glucose. So at that point, your body goes from using glucose as the main source of energy to using and mobilizing fat as the main source. And the body goes into ketosis. So the increase in ketone production is beneficial to the brain in healthy patients. But when you talk about patients with chronic conditions, there's a risk versus benefit involved there, especially for diabetes. Like when you talk about fasting, that's the first chronic condition anyone's going to think of. So if it's not well controlled, the increase in ketone production can actually result in diabetic ketoacidosis, which we all know is an acute complication of diabetes. So this is a small, very informative diagram on what happens when you're fasting. We can see there's lipolysis, proteolysis, and glycogenolysis. All of this is to maintain the energy and glucose levels during fasting. And we spoke of diabetes mellitus. So it's one of the conditions that's actually affected when someone's fasting. So there's a risk of hypoglycemia, obviously. And then when you're fasting, because you're abstaining from water, especially in the Ramadan kind of fast, you don't drink water at all either. So there's a risk of dehydration, which can now cause a risk of blood pressure fluctuations and fasting associated hypotension. And dehydration can also predispose patients to electrolyte abnormalities, and which is one of the reasons why patients with angina and arrhythmias are actually recommended to not fast. And if they're fasting, then it's something that's monitored very closely. Aside from these, we also have conditions like epilepsy and bipolar disorder that are affected by fasting. And epilepsy, Prof. Armias actually mentioned about that. So these patients are sensitive to changes in the drug bioavailabilities, and fasting can increase the risk of seizures, like he mentioned. Aside from that, when you're fasting, like in Ramadan, because of waking up at an odd time of the night, the changes in your sleep cycle are going to actually disrupt the circadian rhythm. And we are all aware that fatigue and disruption in sleep are actually triggers for seizures. So those kinds of patients, it's advisable, if possible, they can avoid fasting. So pharmacists actually play a really big role when it comes to supporting patients who want to fast while they are on chronic conditions. And for this one, the patients are actually advised to speak with their doctor or their pharmacist like 6 to 8 weeks before they start the fasting period. And this is so you can actually perform any risk assessment if necessary. You can review their condition and their treatment and devise a particular plan for them in case they decide they want to fast and they are in a position to fast. And aside from that, like you can counsel, we can have a situation where a patient is not supposed to be fasting or they're at a moderate risk, but then like at the end of the day, the decision is the patient. So they might come and tell you that I still want to fast, like for ABCD reasons, and I do not want to miss my fasts or something. So at that point, what you can do is provide support along with a good team, like a physician, a nutritionist. So you can make sure your patient is well supported during their fasting and their health is not at risk. Pharmacists can actually help in determining if the fasting is safe for the patient through a risk assessment process. And the risk assessment is done basically to develop an individualized management plan. Because each patient is different, our bodies are different, our physiology is different, and you might have two patients with the same condition and the same treatment, but you need to handle both of them very differently. So we can start with doing comprehensive patient reviews. So you're going to check on the medical history, the current medications they are on, and past fasting experience. The last bit is actually quite important because we have some patients who have been fasting while on chronic, while they have a chronic illness, but then there's other patients that maybe say last year they fasted in Ramadan and they were fine, but then this year they've been diagnosed with maybe diabetes or hypertension, and at that point now they are not sure of how to proceed with this. So such a patient, at least if you know how their past fasting experience has been, you can cater to them. And then we have risk stratification. So at this point, you collaborate with the physician involved and you categorize the patient into risk levels. There's different risk levels you can categorize them as. There's low, moderate, high, and very high. Sometimes you're going to see low and moderate grouped into one. So these are examples. When you have a patient with stable hypertension on once daily medications, that sounds like a manageable condition. And considering that the hypertension is stable, their medications are very easy to adhere to. You can actually go around that, and that kind of a patient can fast. We have the moderate risk, which is something that has to be monitored, but it's not so bad that the patient cannot fast. But if it's a point where the fasting is affecting their health, then they can break their fast at some point. Or you can advise such a patient to do alternate day fasting if they're fasting for consecutive days. So they can skip one day and fast another day. With high risk and very high risk, it's not advisable. So these kinds of patients have to be counseled on the dangers of fasting. Aside from that, as pharmacists, you can aid in evaluating medication adjustments. So like Prof mentioned, there are formulations that are extended release. You can change from a formulation of a drug. Maybe there's one drug in a particular class that's taken once daily. There's another one taken twice daily. So you can switch the patient from twice daily to once daily. Aside from that, you can assist in adjusting timings because we have the suhoor and iftar meals in Ramadan. These are different timings from the usual breakfast and dinner meals. So you're going to assess how you can adjust these timings so the patient can be taking the medication either at the beginning and end of the fast, or like you optimize it in a way that they only take once daily, maybe before the pre-dawn meal. This is also going to help adherence because you're trying to create convenience for your patient. And this is also good to do along with the physician. Even something like therapeutic drug monitoring, like for anticoagulants, this is advisable to discuss with a physician before you change anything for the patient. And when it comes to patients on anticoagulants, these kinds of patients are at a risk for developing clots. So when it comes to that, a lot of these patients it's advisable to not fast because when they'll be fasting, we know they're going to have dehydration. And because of the decrease in water, it's going to increase chances of clotting. So that's something to keep in mind. We can also counsel on exemptions and alternatives because sometimes you might not have an option but tell a patient that they should not fast. Despite the fact that every patient has the right to make their own decisions, you give patient autonomy, you are still better equipped with information. So it's best for you to tell them when they cannot fast and when they should not fast. So there are religious rulings that allow exemptions in cases where a patient's health is at risk. So in this kind of a situation, you can actually inform the patient that maybe there's alternatives to fasting. So instead of, if they tell you something like maybe they feel guilty if they don't fast, you can inform them that there's other acts they can do, like give charity, they can make up their fasts at a later point, they can maybe skip some days of fasting, and alternatives like that, so at least they don't feel like they're missing out entirely. Aside from that, you can help your patient make informed decisions along with other providers about how and whether they should fast or not. And then, like, pharmacists are involved in shared decision making. So, in as much as I believe pharmacists are a one-man show, I don't know if I can say that, but we're actually equipped and empowered with so much, and we can actually do so much more than we consider ourselves capable of. In such a situation, it's best to make the final decision along with other healthcare professionals like a physician, a specialist, or even a nutritionist is advisable to be on the team, and the patient as well, because at the end of the day, the decision we are making is about the patient and for the patient's well-being. So they should be involved. And we can also educate the patient on self-monitoring. So you'll instruct the patient on importance of blood glucose monitoring even while fasting, because there are patients who are about at moderate to high risk but still want to fast. Those kinds of patients have to be told to keep on monitoring their glucose like several times a day. So while the ones in the moderate to low risk will monitor like once or twice. And You also need to inform the patient that they need to break their fast if blood glucose is less than 70 milligrams per deciliter. So at that point, even if it's an hour to the meal at dusk, even if it's just 1 hour left from fasting or whatever, you have to inform them that they should not put themselves at risk or their health at risk. And at that point, as soon as they have done a blood glucose test and they're hypoglycemic, they need to break their fast. And aside from that, you also need to inform patients on how to recognize hypoglycemia or something like hypotension, because some of them may be new to it. So you can at least tell them in case you start feeling dizzy, irritable, you have a headache, you're feeling fatigued, you feel like you're out of place or there's lack of coordination. At that point, you know you're not okay and it's advisable to break your fast. And you can also educate patients on meals, on the kinds of foods they should eat, on their meal plans. They need to hydrate. And hydration does not just involve drinking water, it involves electrolytes as well. So it's advisable to tell them to drink like coconut water and maybe watermelon juice or something without added sugars, and eat nutrient-rich meals. So they need to eat fiber-rich foods like whole wheat bread, oats. With respect to oats, though, they should eat unprocessed oats because when they're processed, they tend to spike the blood glucose. So yeah, that's actually quite advisable to do. And some of these points might feel like they can be addressed to other practitioners like nutritionists, but I believe as pharmacists, often we are the first point of contact in that, like patients would rather just go to a pharmacist than book a consultation with a doctor or go and see a nutritionist. So it's actually really good to have information on all of this. So you can at least counsel your patients when necessary. Aside from that, we have continuous monitoring and follow-up. So we are all aware that when we see patients and see them to their medications and their prescriptions, we need to monitor and follow up for as much as we can. So, and everyone nowadays is very tech savvy. We have so many tools we can access, whether it's through AI or just the Google Workspace. So you can assist them by simplifying their regimens. Aside from that, you can help them set up calendars and reminders. So at least even if you have changed the timings of their medications, sometimes they may forget. So in case they have the reminders and calendars, this is going to help them at least keep track of that. You can also schedule mid-Ramadan follow-ups to assess the outcomes. And not necessarily mid-Ramadan, even 2 weeks after fasting, you can check in with your patient and see how they're doing, how they're progressing with their fasts, and how they're adhering to their medications in case they're having any complications, which is why you should also encourage them to report side effects of or any fasting related symptoms. In case there's a lot of people who might not want to mention it because they want to continue fasting, but it's up to you to have that relation with your patient to set a good rapport. So you can actually get them to talk to you in case they have any side effects or any symptoms that you know might complicate their illness. And at that point, in case there's an issue, you can adjust their treatment plans if and when necessary, along with collaboration with their doctor. So we have a small case study. There's a 35-year-old female with hypothyroidism attending a medication review at her GP. So she wants to fast in Ramadan, but she's not sure if she can do it, and she's on medications. And she needs advice on that. She's currently taking levothyroxine 100 micrograms every morning, and she tells you that she's not currently on any other meds, including herbal or OTC medications. And her TSH is in range. And when asked about her day-to-day, she says that she's occasionally fatigued, but she manages that by including small naps after work. So I'll just skip through rather than leave this as a question because of time. So how would you manage? So such a patient we can tell is low risk. Her treatment is stabilized and she has previous experience in fasting as well. Her TSH is okay. So she can actually be advised to fast, that it's safe to fast since her condition is stable. And then in her situation, her medications can be adjusted around the schedule, around the fasting schedule, because they do not have major side effects that may be exacerbated by fasting. So levothyroxine is recommended before breakfast or the first meal of the day, yeah, to optimize the absorption and avoid any drug-food interactions. Because we know for foods high in calcium, iron, something like coffee, foods rich in fiber, they would hinder or they would reduce the absorption. So at this point, you can advise her to take it at least 30 to 60 minutes before suhoor, which is the pre-dawn meal. And once the patient is comfortable with that, they can be assured it is safe to fast while on the current medication. So you will advise the patient to consult her doctor or the pharmacist in case she's having any changes in her symptoms or health. If she feels like maybe it's affecting her or something does not feel right, she needs to inform immediately and not to stop the prescribed medications without any prior consultations. Because like Prof mentioned, we have some patients who will just stop the medications when they decide to start fasting, and that can actually put them at a greater risk. And I'll also really say this again, each patient should be reviewed on a case-by-case basis. So you can have two patients with the same conditions and the same prescription, but care should be individualized. Every patient is very different. You can't apply the same to another one. So that's basically it. And from that, we can see that as pharmacists, we actually play a really big role in preventing complications and optimizing care for our patients during Ramadan and fasting in general. And in as much as we're empowered with a lot of knowledge on how to handle patients, interdisciplinary collaboration is important. It's okay to ask a doctor, it's okay to ask a nutritionist, and at least rather than assuming, because it's your patient that you are putting in priority. And aside from that, proactive patient engagement and planning is key to successful chronic illness management during Ramadan. So I hope I haven't left anything out. I'd like to end there. And any questions can be put in the chat and we will get to them at the end. Thank you so much.
Thank you, Dr. Bushra. And just to reiterate, if in case you have any questions, please put them in the Q&A section. I'm seeing Prof. Ermias has answered most of the questions, especially on diabetes that have been asked in the Q&A section. For those on YouTube, please ask in the chats there and your questions will be answered also. Next, our next and final speaker is Dr. Muna, who's going to talk on impact of fasting. So Dr. Muna, please.
Good evening, everyone. I hope we're all doing okay. Go ahead, can you hear me?
Yes, we can hear you.
Okay. Thank you to the PSK team and the attendees for this very informative meeting, and thank you to Dr. Ermias and Bushra. That was very educative. So I'm going to share my slides. Just give me a minute. Okay, I hope you guys can see them.
Yes, we can see your slides.
Okay. My name is Mona Mahmoud, and I am a hospital pharmacist. So today I'll be talking about a very interesting topic on the genetic impact of fasting on our body. And I just want to say, Bushra was emphasizing a lot that the care should be tailored to a particular patient. And I think this is where we talk about that, because genetically we are all very different. So you could be giving the same medication, the same food to two different people, but the way the body responds will be very different. Okay, so before I start, I want to talk about some key concepts here. So this is the types of fasting that people can do. I'm not speaking in the context of religion. This is just any kind of fasting, can be intermittent. So what you're doing is you're fasting, maybe like in Ramadan, it's a diurnal fast. So you fast during the day and then at night you're off, or you fast for 24 hours or something like that, and then you skip 2 days or something like that. So that's called intermittent fasting. So you just stick to a specific time that you'll not be eating, and then there's a feeding period after that. And then there's another type of, it's not a fasting per se, but it's just a calorie reduction. So there's a way you calculate the requirements, the calorie requirements per day for the body. And then if you're trying to lose weight or for health reasons, you just only consume maybe 60, 80% of your daily calorie requirements. And then another important thing here is it's something called ad libitum, which means that it's like the opposite of fasting now. It's, I think, Latin for just you do something at your own desire. So like the control groups in some of the studies I'll share with you. So meaning they're just given unrestricted access to food. So the time you eat whenever, however much you want, and there's no, it's just can be sugar, fat, protein, whatever. And then protein synthesis is an important topic here because everything in our body is maintained or regulated by protein synthesis. So the production of structural proteins, neurotransmitters, hormones, and things like that is all through protein synthesis. And then another thing is epigenetics, which is a study of how external factors modify DNA expression. So what epigenetic studies is the changes that happen to your body now. If, let's say, someone is fasting, what happens is that it changes the way a DNA, a specific gene or a DNA is expressed. Yeah, so an example of a DNA modification can be a methylation of a histone. So a histone is the protein that the DNA is wrapped around, because DNA is like 2 meters long and then it has to fit inside the cell. So it's usually wrapped around the histone. So if, let's say, you're adding a methyl group to the histone, what that does now is the DNA is wrapped very tightly around around the histone. So that then causes an effect on the gene that it's not going to be expressed. So you're basically switching off a gene. And then if you add an acetyl group to the histone, what that does is now it's the DNA is loosened around the histone. And then now it's like you're switching on a gene. So whatever effects it will elicit will go on. And then another thing here is transcriptomics, which is basically how they're finding out this information. How do you know what changes are happening in the body? Just based on, I think, after fasting or exercise, or depending on the type of food you take. So transcriptomics, what it does is you basically take a sample, maybe from the adipose tissues or from the brain, and then they just take, it's like they're enabled to separate all of the RNAs in your body. And what RNA does is it's the one that, I guess, leads to protein synthesis because it causes translation of proteins. So that's how they find out the information that I'm going to share with you. And then a network analysis is also another way of finding out what now these effects do to your body, what fasting does to your body. So if there are two types of genes that are correlated, so if they find out that gene A expression goes up, then they're able to conclude that gene B goes down, and then this is how the effects are coming about. Okay, and then a telomere is a protective cap at the end of your DNA strands. I don't know if you've seen that picture of a gene. Sorry, I didn't include any graphics. Yeah, but at the bottom, you can think of it like a sock. It's like a DNA nucleotide strand at the end of your DNA. Yeah, so it's basically protects the genes and is a determinant of how long someone will live, I guess. And I'll expound on that. So the first thing I'm going to talk about is the genetic effect of fasting on the brain. So intermittent fasting and calorie restriction have a beneficial effect on the brain because they increase plasticity, learning, and motor performance. So what plasticity basically is that your brain is able to form new connections and then just structural changes that people in the past did not think that the brain could do that. So they thought if you are born then you develop that your brain would stay like that. But recently they've discovered that your brain is actually capable of changing depending on how much you read or you learn, things like that, the exercises for that. So during fasting, there's a protein called BDNF that is increased. BDNF is a brain-derived neurotrophic factor that now causes the neuroplasticity and enhancing learning and motor performance. And then it was also discovered that BDNF increases during exercise. So it says that if, I guess you're trying to develop your brain, fasting and then exercising at the same time is like a very good way of trying to do that. And then BDNF also supports neuronal growth and overall health of the neuron. Yeah, and then it was discovered that intermittent fasting can also reduce the occurrence of neurodegenerative diseases such as Alzheimer's, Huntington's, and amyotrophic lateral sclerosis. So there are some studies that were done in some Muslim majority countries that the occurrence of these conditions were fewer than compared maybe to people in the West, in America, and in the European countries. But there are a lot of factors that come into play as far as neurodegenerative diseases are concerned. Yeah, so it's not just something that you could have just said is because they were fasting that the risk is reducing. So it's just a complicated matter, but it has been proven to reduce the occurrence of these conditions. And then there's another study, I'll talk quickly about it, that they discovered that the brain protects you from intermittent fasting protects the brain from stroke-induced brain damage by suppression of inflammation and changes to cell death pathways. Yes. So the study was done on some rats. So what they did is, so there was a group of rats that was ad libitum control group and then the intermittent fasting group. So there was a group that was fasting for 12 hours and another for 16 hours. So what they did after the fasting period is they occluded blood flow to the mid-cerebral artery. So basically they were inducing ischemia to the brain, and then after some time they allowed for reperfusion of the brain, and then after that then every hour they took a sample from the brain from all three groups, and then now through the transcriptomics they're able to find out the genes and the proteins that were being encoded in those states. So what they found out is, especially for the 16-hour group, is the body was producing so many proteins that are protective to the brain. There was less cell death even after the stroke. And there are almost around 70 genes that were switched on for the body to protect itself from now the lack of oxygen that was happening. And then compared to the other group, I guess after the ischemia, the stroke, it's just the cells kept dying and dying and dying. Yeah, so that's a very interesting effect of fasting. And then on the immune system, there is a reduction in chronic inflammation. There is fasting and calorie restriction reduces the body's ability to produce harmful free radicals by reducing oxidative stress. There is damage to the repair to damaged DNA and autophagy. So what autophagy is basically, you can think of your body as cleaning up all the dead or just any protein or cells that were not doing good. It would take care of that. And then there is an increase in tumor suppression. The TP53 gene, which is a tumor suppressor, was increased, and then a reduction in pro-inflammatory gene expression. And then another interesting effect of this is that they found out people who fasted were less prone to getting at least 13 cancers. So if obese people were at risk of getting, let's say, 50-something cancers, then the people who are fasting with the normal BMI will have 13 less cancers, I guess. Yes. I don't know what I'm trying to say, but yeah. And then, so in some, I guess, some doctors, cancer chemo, I guess, with some oncology centers, what they do is they encourage the patients to fast now, because especially after chemo, so that the body now would start healing itself. And then also because of the tumor suppression, so it's like an adjuvant to chemotherapy, radiotherapy, and immunotherapy. Okay. And then there was also another hypothesis that some people, they did a preliminary study that people fasting before chemo would, I guess, reduce the side effects of chemo. So they had a few cases of that, but then the study did not go on. So it's recommended that this is only done if it's a clinical trial, because it's not a proven theory yet. And then the effects of intermittent fasting and calorie reduction on chronic conditions. So what they do is they reduce fat accumulation by breaking down fat, and also increase insulin sensitivity, reduce blood glucose levels, even without changes to the diet. So what this means is, even if someone, on the days that you are not fasting or you're not observing the intermittent fasting, you just eat whatever you want. So high carbohydrates, sugars, all of that. So they found out the people who are doing the intermittent fasting, the glucose levels was more regulated to people who are just eating at will, I guess. Yeah. And then fasting also can lead to reduction in body weight. And yeah, and then also on the other study on the mice that they were doing, they discovered that the group that was being, I guess, doing the intermittent fasting, that they gained weight, less weight, and at a slower rate than, I guess, someone who's just eating whenever. So and then a reduction is in waist circumference, body fat percentage, by reduction of the FTO gene. FTO is a fat mass and obesity associated gene. So they discovered that when obese patients were made to fast, then the levels of these genes in their bodies would go down. Yeah, and then fasting can also cause a reduction in blood pressure, an increase in ghrelin and adiponectin levels. So ghrelin is like a hormone or a protein that tells your body when to eat and when to stop eating. Basically, it's telling you you've had enough, then now you stop eating. So they say the levels of ghrelin is higher in people of a normal BMI, because now the body knows when to stop eating. And yeah, And adiponectin is a hormone or a protein that's produced by adipose tissues when someone is fasting, and it increases insulin sensitivity. And intermittent fasting also has an anti-atherogenic effect, so it prevents accumulation of plaque in your blood vessels. Yes, okay, so I'll go on to the effects on the GI system. So there's an interesting thing that happens when people are fasting. Usually you fast the whole day, and then when now you want to eat, suddenly it's like you've just had a sip of water and you feel satisfied. So there's a scientific explanation for this. So what happens in your body is that there is a CDX2 transcription factor that turns off these two genes that I've listed here, tumor necrosis factor, alpha and TGF-beta1. So when they're turned off, there are some changes that happen in your stomach, in your intestines. So the villi in your are usually a bit longer when someone who's normally eating. So when you fast, they become shorter, and then a crypt is like a shallow opening where new cells regenerate from in your GI system. So they become shallower, and then the overall intestinal thickness becomes reduced. So why the body does this is because it knows now there's no nutrients to be absorbed because you're fasting. And since absorption and the whole thing, what do you call it, digestion, things like that, need a lot of energy. So the body is trying to reduce that. So it's not using up all the energy when someone is already fasting. So that's why the stomach, I guess, for lack of a better word, you feel it's become smaller. So when you break your fast, you feel fuller quickly. Yeah, so they said after you break your fast, it takes like a few maybe minutes to hours for your stomach to regenerate and go back to its normal size. And what is recommended as Muslims is you break your fast with something like dates, because it has simple sugars like sucrose and fructose. So when you break your fast, it's like an instant boost of energy, but then it has the fiber so that you feel satisfied very quickly. And then as your stomach goes back to its normal size and normal functionality, then you can eat, I guess now, as later on, you can just have however much food you want. But that's also not advisable, because now it's like you're undoing all the good effects of the fasting on your body. So even if you fast after, it's recommended that you have a normal amount of food, I guess, in speaking in nutrition terms, normal and healthy. You still have a high protein, high fiber diet, and not the high carbohydrate diet that we usually do. And then another thing is that fasting affects longevity and quality of life. So the telomeres I was talking about at the beginning, the protective caps of your DNA, they are a predictor of how long one can live. So if it's said that if the telomere is long and more stable, then you're likely to live a longer life than someone who has a shorter telomere, which shorter means more instability. And then there are these genes, the SAT1, AMPK, FOXO3 genes, which are also linked to longevity, which go up during fasting. So like an example, the AMPK gene is AMP activated protein kinase. And what it does is in your body, when it's starting to feel the reduction in energy because you've been fasting the whole day, it causes, I guess, the body to start getting other sources of energy, like from the fat. So now, if you're fasting, you're able to break down fat, reduction in body weight, and things like waist circumference and things like that. Yeah. And then there was a study on mice that was done, and they found out that the mice that were subjected to the intermittent fasting had a 20% increase in lifespan compared to the ad libitum control group. And the three main factors that are involved in increasing the quality of life and longevity is one, improving glucose regulation, two, suppressing inflammation and increasing stress resistance. So yes, so how can we apply this knowledge now in pharmacy? So we can use intermittent fasting and calorie reduction as a means of reducing or eliminating the risk factors for chronic conditions such as diabetes, hypertension, and other metabolic and hormonal conditions, together with exercise and healthy eating. And then it's, as Doc and Bushra mentioned earlier, it's important to note the genetic differences between people, and it's to tie, I guess, your interventions to specific people. It's not like one fits all, I guess, approach. Yeah, so you notice even the fasting itself has different effects on the people. So some people are able to fast. As for some people, I guess it overpowers their body. So yeah, people respond differently to a lot of things. So it's important to put that in mind. And then in some countries where the Muslim population is higher, they have a fasting friendly medical guide, I guess, medicine guide. So I guess if you're a pharmacist in a population that's mostly Muslims, that you can have this information firsthand, or you just prepare yourself, even if it's not for religious purposes. For people now, we've learned who are trying to reduce the risk for diabetes and hypertension, you can give them this information so that they're able to do it, I guess, safely. And then to understand the effects that fasting can have on different groups of medicines, such as insulins, oral antidiabetics, warfarin, NSAIDs, and I guess it matters for every other drug because the body is changing. And then in the future, maybe we can use fasting as a means of preventing or reversing some of the effects of chronic metabolic conditions. Yes, and then if we can use genetic testing to help tailor fasting protocols for patients with chronic conditions, and the potential of AI-driven health monitoring to track fasting-induced genetic changes in real time. Yes, so these are some references if anyone is interested in reading further. Thank you for your attention, and I'll give it back to Cohen.
Thank you, Dr. Muna, for the presentation. So I think right about now, we're going to go to the Q&A session. If there's anyone who has a question, with the guidance of Dr. Hezron, I think, are they going to raise up their hands so that they can speak? And I'm seeing there's a question by Dr. Lucas Nyabero. I'm not sure which speaker it was addressed to. There's a question in the Q&A chat. So we can have perhaps 2 or 3 questions, then wrap it up with that.
Hi, Cohen.
Hi.
Yeah, so I'm seeing a question from Lucas Nyabero. He's asking where the genetic studies were done, what the overall inclusion and exclusion criteria, the age of patients were, yeah, and such questions. Yeah, so they were very lengthy studies, and in the interest of time, I guess initially the talk was going to be around maybe 10 minutes. So I did not include all of that information, but if you're interested, then you can have the references to that. I can also share the studies with you. But yes, all of that information is there.
Okay, thank you, Dr. Muna. I've just seen Dr. Lucas clarify that the question was to you, so you'll do as you've said. Okay, since there's no other question, I'll hand over back to Dr. Hezron and to say thank you so much to the speakers and for all of you for attending the great interaction. Yeah, and with that, I'll hand over back to Dr. Hezron from PSK to wrap it up. And as Dr. Hezron comes in, there were so many requests for the slides to be shared. So perhaps you can tell us how the attendees will get access to the slides from Dr. Muna, Dr. Busha, and Prof. Ermias, who kicked off the session. Thank you.
All right, thanks, Dr. Cohen. And thanks to our presenters, Prof. Ermias, Dr. Muna, and Dr. Busha. I think that was a very insightful presentation. And we've gotten some very good feedback from our attendees. And I think I see most of the questions that had been asked during the session have been answered on the Q&A tab. So I think that covers us for the session, considering time has really gone as well. So for those who had joined us on YouTube, there's a QR code that is currently being shared. So kindly just scan that or use the link that has been placed on the side. Just type on your Google bit.ly _fasting_webinar, and you should be able to register your attendance for the session. So meanwhile, I think we'll go into the announcements. And the first one is on this upcoming webinar, which is happening this Thursday, on dissemination of family planning guidelines. And this is session 2. Remember, we had session 1 in January. So this is going to be session 2. And we'll be having Genotai, who is an OPC program manager at URADCA. So kindly ensure that you register for that when we share the registration link in the groups. Another upcoming webinar that will be happening on 27th. And this is by Helion. And we'll be having our very own Professor Hermes again, who will be speaking specifically now on low back pain solutions, targeted treatment options. So for those who will be having any challenges registering on the Helion platform webinar, kindly reach out to us. All of those who've been reaching out to us on our inbox, we've been able to assist them and they've successfully joined the webinar. So if you have any challenge, kindly reach out to the PSK communications number and you'll be assisted. It's a very simple process. Once you've registered for the first time, it should be very easy to join the following webinars. Another upcoming webinar that will be happening on 25th of March is about the conference. And this is a conference trivia night webinar. And during this session, you'll be learning about the various aspects of the conference, starting from the abstract. If you have any questions on that, on the registration process, if you have any questions on that, how to make your payments for the conference. So kindly come with all your questions during that session. You'll also be meeting the full conference committee and also just learning more about the conference. So kindly have that on your calendar. It's already been added on the PSK calendar. You can add it so that you're able to attend. A reminder is we're almost reaching the end of the early bird ticket, which is on 31st of March for those who are coming for the conference. So I'd encourage you, if you've not booked your slot, kindly do so. Ensure that you do that before 31st of March to take advantage of the early bird ticket. The call for abstracts is still going on. So if you have any abstract you'd like to present during the conference, you have up to 15th of April to submit your abstract. These are just the conference rates. Remember, the early bird is closing on 31st of March. The regular bird opens on 1st of April to 30th of April. Then the final thing is just a reminder on reporting of suspected adverse effects.
We have three options, two options for the healthcare professionals using the PVAS system, where you can visit pv.pharmacyboardkenya.org, or the mobile application MPVAS, where you can download from the Google Play Store or the Apple Store. For the members of the public, you can use *271#. Again, for the CPDs that you've not received for the events that have happened, it's because we've not had enough subscriptions on the PPB portal. So we are unable to send you the CPD tokens. So if you've not subscribed to any of the events that has happened the last 2 weeks, kindly do so. That way the CPD coordinator will be able to send you the CPD points. And for this event, just use the keyword fasting and you should be able to find the event easily. For those on YouTube, you can scan this. I'll leave it on for the next 3 minutes so that you can just subscribe. So as we close, thank you so much again. Our esteemed speakers, Prof. Ermias, Dr. Bushra, Dr. Muna, Dr. Fatuma, who was part of the team that was organizing this, and finally, Dr. Cohen and Ove for moderating the session. Much appreciated for those who've been able to attend, both on the Zoom platform and those who also able to join us on the YouTube page. Thank you so much. So we're looking forward to having you in the next webinar this Thursday. So I'll be leaving this on for the next 3 minutes. For those who just attended on YouTube, you're the only ones who are expected to sign up on this QR code. Anyone else who joined on the Zoom platform, you're okay. You don't have to sign up on this QR code. Thank you and have a good night.